And welcome everyone to this week's Maternity and Midwifery Hour. My name's Sue Macdonald and I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals. And it's my pleasure to be chairing this session this evening. And this is Series 16 and Session 8. This is 5 years into the Maternity and Midwifery Hour. And we're joined by Tina Prendeville, Denise Barnes and Emma Tomlinson. So welcome Denise, Emma and Tina. So we've got a nice group of three, which is lovely. And we're going to ask them to share a moment of the week. So shall we start with Denise? Your moment of the week, please.
Thanks, Sue. My moment of the week is I have discovered my first session of yin yoga. I'm quite into my exercise and I like to run and do a lot of keep fit. And I've now discovered that yin yoga involves lying down and relaxing for a whole hour.
Nice.
So that is my lovely discovery for this week.
That sounds very nice. But do you have to do anything else apart from just lie down?
Turn over, lie on your back, lie on your front.
Well, that sounds pretty good to me. Thank you for that. How about Emma? Your moment of the week, please.
Thanks. So my moment of the week is it was my son's birthday and I managed to survive a 7-year-old's party, looking after 22 children and being responsible for the majority of them because a lot of the parents dropped them and went to the pub. We got through it.
So you didn't have a parents' party in a different room?
I very much wish we did, but no, we didn't. They all went to the pub.
You were merely looking after a few 7-year-olds.
Absolutely.
Easy. Oh, wonderful. That sounds good. And I think a little period at the pub might have been quite fitting, I think, for that. So congratulations to your son on 7th birthday.
Thank you.
How wonderful. All that energy, I bet. Fabulous. Okay, and we'll finish with Tina for a moment of the week.
Thanks, Sue. I think for me, my moment of the week was finding out about 2 days ago that my daughter had arranged for her and me to go see Lady Gaga later in the year. So I'm very excited. I've always wanted to go see, yeah, absolutely, get all that pressure and stress out. But yeah, so really excited to do that later in the year at the O2. So yeah, that's very exciting.
Well, that sounds fantastic. They all sound fantastic moments of the week. So thank you for sharing them. Now we can let our speakers have a little rest now. And I'll just run through a few things before we get to the 7:10 start of the presentation. So I just need to remind, I know there are around 200 new registered people coming in this evening. So welcome to you. And also welcome to our old friends who come every week. And this might be Wednesday that you're coming, and it might be Thursday, Friday, Saturday, whenever you come. And just to remind you that this whole maternity midwifery hour started on the onset of the first COVID-19 lockdown in the UK in March 2020. I can't believe it's 5 years, but it is. And we set up the maternity hour really to make sure that midwives, student midwives, people in the maternity services mainly, that was our main focus, really had contact each week where we could speak about midwifery things in the context initially of a lot about COVID and the changes to services, changes to education and all the things people were doing, which were fantastic at a time of great stress. And we've carried on. We carried on to the 5th year. And it's been a really useful way of sharing knowledge and practice development and the things that we need to know as midwives. And we also, I have to always remember, we always record everything, the Maternity and Midwifery Forum, everything's recorded. So if you should have a power cut or have to rush away, you can always catch up at a later point because everything is recorded. And we like also, if you watch this evening, I think you're going to really enjoy it and find it quite thought-provoking and useful for practice. You might well want to share with colleagues, and especially other students if you're a student or other midwives. And we like you to share. We don't want to keep everything secret. We want you to share with all your colleagues and really get discussing it because that really helps you learn and understand all the issues that we're going to talk about. And you can access this afterwards because our lovely friends at Matflix look after and archive all of the presentations from all of the maternity and midwifery hours. And we're over 200 sessions now, 200 hours. think it's over 200 hours, plus all the maternity and midwifery festivals. We have a huge bank of fantastic presentations from the great and the good from everybody. And you just have to go and sign into Matflix. If you are lucky enough to be in an institution, a university or an NHS trust with a subscription, obviously you can just go in for free, or you can have your own subscription, and it's tax deductible, I might add. And you can go in and have a look at the presentations. Very useful if you're looking at revalidation for the midwives, every 3 years thing. Student midwives, if you're doing any projects or any practice development things for any midwives, or preparing for an interview, really good way of getting updated. Health warning, and I've given this health warning now three weeks in a row. Once you start going in there, you will find it's a bit addictive, and you find out lots of new things. You might just waft into things that you didn't actually go in initially to have a look at, but suddenly you find you're hearing something really interesting and useful in your practice. So I recommend it, but with a health warning. Okay. And I also need to say to you, look after yourselves. And I always say this, and I've said that right from the beginning, because what I think it highlighted the whole COVID lockdown thing was how precious how precious we all are, but how midwives, student midwives, all those people providing care to mums and babies need to look after themselves, because we often look after other people before we do look after ourselves. So do that now. Okay, now I mentioned the Maternity and Neonatal Safety Summit in July, addressed by Wes Streeting and chaired by Sean Linton, who's the Sunday Times editor. And that's being organised, I think, by the RCM, but you might have seen adverts for that. That might be come of it, some interesting things at that time in July. I also need to remind any of you who are in the RCM as a member not to forget to vote for your RCM council, because I know the papers came around and the closing day is Friday. Also, again, maternity services are in the news, and this time it's Leeds Teaching Hospital, and there's been a BBC report with some feedback from parents really highlighting the loss of mums and mainly babies, but trauma also that experienced by families. And the key things that they were highlighting were parents not feeling listened to and experiencing a lack of compassion. I always feel very sad when I hear those things, because I know it's probably because people are really stressed, they don't know what to say, or they feel they don't want to say, I don't know. But parents feeling very alone at a very difficult and painful time. And I haven't looked at the full report or anything as yet, but I think I've put a link on the resources, so have a look at that. I think it's especially poignant because it's this month is SANS Awareness Month, and this evening we are looking at stillbirth, a very deeply challenging outcome of pregnancy, and families often look to us as midwives for support and answers. And in this session, we're going to look at it from a very genomic point of view. And if you don't know what genomics are now, you are going to soon know what they are, because we've got our three lovely speakers who can really make that clear. And so we're going to be looking at how genomic testing can become a valuable tool in understanding some of the causes of stillbirth and where the limitations are. Because, when somebody comes up with some wonderful answers, people think, oh, it's the answer to everything. It's not necessarily the answer. There are limitations. And this will help us really support families during a very difficult time. So we've got three wonderful speakers. You've already heard their little moment of the week, and I'm going to introduce all three because they're all going to be speaking in turn. So rather than doing one at a time, I'm going to do them all. So firstly, I'm delighted we have Tina Prendeville, lead midwife for the North Thames Genomic Medicine Service Alliance, based at the Great Ormond Street Hospital and hosted by Chelsea and Westminster NHS Foundation Trust. And this enables a regional leadership roles to support the implementation of national and local transformation projects, ensuring mainstreaming of genomics in midwifery activity, which you're going to become very aware of as Tina speaks. So this is very much bringing together providers, multidisciplinary teams and diverse communities to work in partnership across geographies all across the way. Also, Tina's a senior clinical research midwife at Imperial College London and involved in research project, and also part of the Tommy's Baby charity team, providing expert midwifery-led advice, pioneering research and evidence-based information. So that's Tina. And then we have the wonderful Denise Barnes, who is the lead midwife for genomics in North Eastern Yorkshire Genomic Medicine Service Alliance, the GMSA. And she works as the midwifery lead on perinatal transformation projects. And working within a multidisciplinary team in fetal medicine has driven her to explore how to improve access for women and their families to the informed offer of support and testing from perinatal genomics service. And she's also participated in 3 patient videos designed to offer more personalised information, and has used some of the findings from the transformation projects to increase awareness of genomics in local pregnancy loss pathways. And outside of work commitment, she enjoys running with her dog and spending time with family and friends. This is what we need for our general health and well-being. Fantastic. And then finally, we have Emma Tomlinson, who's been a midwife for 12 years and is the specialist Rainbow Clinic midwife at St Mary's Hospital in Manchester, providing care to families before and during their pregnancy after loss. She's also qualified in 3rd trimester ultrasound scanning and scans weekly at the Rainbow Clinic in Manchester. She has supported the rollout of the Rainbow Clinic model of care and successfully supported the setup of 30 other UK Rainbow Clinicals and 3 in the USA. Fantastic work. She also works as a research. I don't know how you managed to balance all these things. Fantastic. Also works as a research midwife at St Mary's Hospital and is a Tommy's midwife working in the pregnancy helpline, also providing advice, reassurance and support to families during and after pregnancy or at any point during a pregnancy loss. So welcome to Tina, Denise and Emma. And now the screen is yours. And thank you so much for coming this evening.
Thank you, Sue, and thank you for the lovely introductions. And on behalf of myself, Denise, and Emma, we just want to say how happy we are to be here this evening and contribute to this really important series. And it's an area that's gaining momentum and interest, particularly in our midwifery community. So we're very grateful to contribute. Our topic tonight is, as you said, genomics and stillbirth. So we thought it was really important to kind of just pause and reflect at the beginning of the session, and to allow people to think about perhaps their own experiences. And we understand that certainly because of the incidence of pregnancy loss, there'll be a huge proportion of people on this call this evening that may have been personally affected by pregnancy loss or stillbirth, whether it be themselves or a loved one, or even for our colleagues working in this space who may have encountered particularly traumatic experiences. We know it's difficult to process emotions around this, so you've already mentioned that, how we need to make time for ourselves to process. And we just want to reinforce that and say, for people who are perhaps finding it difficult or challenging to process thoughts and emotions around pregnancy loss, particularly stillbirth, there's a wealth of help and resources out there. And Emma's going to really go through some of those resources later. So our key message is to be kind to yourself, and you don't have to do this alone. So I'm just going to give an overview of the aims of our session. And firstly, we're going to look at the incidents or the data around stillbirth. We're particularly going to focus on the recent Embrace report, which was published last month. So it's a really up-to-date kind of snapshot of where we are, just to get a sort of an assessment of how the land lies. Hopefully, we're going to be raising awareness of the impact of genomics in stillbirth, and particularly looking at it from the patient perspective through the lens of a case study that Emma's going to share with us a bit later, and really to see what patients want or experience from the process. And to do that, we're also going to describe current clinical practice for genomics around particularly unexplained stillbirths, where parents don't get answers to why this devastating event has happened in their life, and really just to ensure that patients are getting access to good service and good testing. So we're looking at particularly the ONS data. And it's important to reflect on the national maternity safety ambitions that were published in November 2015, with the target or ambition of halving the stillbirth rate from 2010 and to achieve that figure by 2025. And although there has been a decline in the rate of stillbirth and neonatal death since 2010, unfortunately the data has stagnated, and you can look at that graph in front of you where you can see the line is sort of quite nicely decreasing, and then it sort of levels off. So unfortunately we're not going to achieve that target as set back in 2015, and sadly experts have calculated that not meeting that target has meant that approximately 2,500 babies will have sadly lost their lives by not meeting that target, which is devastating. So we're going to just focus a little bit on some of the highlights from the Embrace report. And as I mentioned, many of us working in maternity or an interest in health within the UK will be familiar with this report. It's an annual report, which is sort of a snapshot, a state of the nation, if you like. And we're going to look at some of the key findings around baby deaths. So you'll see the graph to the left, and we can see this sort of downward trend, which is great news. It's 23% lower than 2013, but again, not at the pace that we'd hoped, not at the decline that we had hoped, but there is some improvement when you look at the overall rate of stillbirths. And thankfully, across all of the nations, we've seen a decrease in those numbers, so that is reassuring, but as we said, not at the pace that we had hoped. I think important to point out, and data that we won't be surprised to see, sadly, is that stillbirth rates remain the highest among babies born to mothers living in the most deprived areas. And when we compare that figure on the graph on the right, it's quite staggering, the difference. Not surprising, unfortunately, we know that deprivation is a significant risk factor, and that's even taken into consideration that we have seen a drop of 8% in this rate, but it's still significantly higher than the least deprived communities in our country, in the UK. Also, sadly, we will not be surprised to see these kind of statistics. We know that, sadly, Black babies are still more than twice as likely to be born stillborn compared to white babies. We have seen improvement. We remember the start of the campaigns, 5 times more, and lots of groups really passionately bringing this important information to the forefront of maternity care. We have seen some improvement in both Black and white babies, but disturbingly, looking at this chart, we're seeing an increase within Asian baby community. We don't know why at this point, but there's certainly something that's continued to be explored. If we look at the common causes of stillbirth, actually these have remained relatively unchanged, and perhaps it's not surprising as midwives and obstetricians or women working in, or men working in maternity space, that main complications that affect the placenta, the cord, fetal health have, in fact, as I said, remained unchanged. But what is concerning is the huge percentage of unknown causes, and this always comes as a shock to me and all of us working in this space, that still for a large proportion, over a third of cases within the UK, we still do not know why stillbirth happens. The data varies globally. In some countries it's much higher, and that may be because of intervention and surveillance and testing, but within the UK we still don't know about a huge proportion of our women and birthing people who experience stillbirth. And there's some of the key highlights from that report. There's a lot of really interesting reading, a lot of very relevant reading, and if you want to get a bit more information, a bit more granular detail, I suggest you just use that QR code. So as we've mentioned, this huge percentage of unknown causes, and I guess the question this evening for us as experts within this field is, can genomics help? before we really explore that in more detail, Sue set me the task of explaining this in simple terms. I'm really going to try in about 1 minute. So we're really familiar generally with the term genetics. So we know that our genes is how we transfer traits and conditions down from generation to generation. We kind of got a good handle on that, haven't we? And most people working in healthcare have an overview of what genetics is. Genomics is blowing out that picture, opening that lens, so that it's encompassing not just the genes, which are the protein coding parts of our DNA, but it's also encompassing a huge amount of other DNA that we think previously was called junk DNA because we didn't think it did anything. But of course, now because of new technology and sequencing technology, we understand that this DNA actually plays a really vital role. It switches genes on, switches genes off, and really has an impact on our health and our predisposition to disease, for example. And genomic medicine, encompassing this information, has the potential to have a greater understanding of how our bodies work, how our genes interplay, what switches them on, what switches them off, and also how we can personalize medicine. And we talk about that on maternity, don't we? And we will talk about that a bit more. But using this technology gives us the opportunity to harness information that improves outcomes for mothers and babies. So how can genomics help? Well, Emma's going to talk a little bit to this, but I think it's important to know that genomics can pinpoint genetic abnormalities. It can help us inform pregnancy planning. It can help us plan for future pregnancies. And Emma's going to talk to the model that we use in the Tommy's Rainbow Clinics, how to manage these pregnancies. But also it's to give answers to parents, for going through such devastation, and to be quite simply told we don't know why is really difficult. And we know that these parents aren't going to just get over it. But what we need to do is make sure we uncover any information to ensure that if there is a genetic cause or there is something in their family history that we can identify and help manage the next pregnancy. This is really important information. So I'm just going to hand over to Emma now, and she's going to talk to a little bit of some of this research. Thank you, Emma.
Thanks, Tina. So as Tina's just said, having the cause of a stillbirth identified can really help families to try and find closure, alleviate some guilt and shame, and support decisions about pursuing another pregnancy, including planning for next pregnancy as well. Now, we know the majority of stillbirths, about 81% of stillbirths, they do occur in women with no apparent risk factors. However, as midwives, obstetricians, student midwives, we're all aware of the modifiable risk factors for stillbirth, such as smoking and alcohol. We know that smoking increases the risk of having a stillbirth kind of between 1.3 and 1.6 fold, and alcohol between about 2 to 3 times increases that risk. But really interestingly, having had a previous stillbirth increases that risk 5-fold. So these families, when they have previously had a stillbirth, they're at a huge increased risk of then going on to have another stillbirth in a subsequent pregnancy as well. So can genomics help? It's really important to take into consideration that pregnancy loss, to try and pinpoint genetic abnormalities, and that'll help inform future plans for that next pregnancy. Like I said before, it can sometimes provide emotional closure. We sometimes get answers, but again, it's really important to have that open and honest conversation with families that sometimes we actually don't find a cause and we don't find an answer. And that can be a really challenging conversation to have with families. And it's important to then discuss their thoughts, their feelings, and more importantly, their expectations as well, and then truly provide tailored care into that next pregnancy. So thinking about this, the Rainbow Clinic model of care was designed on the back of these considerations and these thoughts. And there was a study published in 2016 looking at pregnancy experiences of subsequent pregnancy after loss in the UK. And really sadly, only 40% of UK hospital trusts actually had a written hospital guideline to support the care around pregnancy when they'd previously sadly lost a baby. And really shockingly, almost 52% of families, they really just didn't feel as though they were well informed going into that next pregnancy. They didn't feel prepared for that pregnancy after loss either. And so again, that's kind of where the Rainbow Clinic model of care stemmed from. So we started in 2013 at St Mary's in Manchester, and the model of care was designed by Professor Alex Wiesel, and we have now grown to a much larger team. We run a Rainbow Clinic every Thursday. We have a full scan day, and in our last year, we cared for 500 families who'd sadly lost the baby, and then we're going through that subsequent pregnancy after loss. We offer the postnatal debrief usually about 14 to 16 weeks after their pregnancy loss, where we really do set the plan of care as to what's going to happen, talk through investigations that they've had previously, and make sure they really feel as though they know what's going to happen in that next pregnancy, where to go when they're pregnant, and what to expect more than anything. We provide continuity of care, so it's a very small team, as I said earlier. They don't have to retell their story over and over again, and they have our contact details to call us ad hoc for extra reassurance, extra appointments if they feel as though they need to come in. We work really closely with fetal medicine unit and the genetics department as well to truly provide that tailored and individualised care for families. So we felt it was really important to look at a case, look at a family that has been cared for in Rainbow Clinic, and really try and bring alive this idea of what we provide tailored care for, why it's so important for families. So in this case study, Sarah and John, we're going to just go back to their initial pregnancy and just talk a little bit about that pregnancy first before we talk about the Rainbow Clinic care that we offered. Their early antenatal care was very uneventful. They had a normal 12-week scan, a low-risk nuchal screening scan, but came in for their anomaly scan at almost 21 weeks, and there was a query whether there was some form of brain anomaly found at that scan. A couple of days later, the family were referred into the fetal medicine unit, and again, it did confirm that there was some form of abnormal brain anatomy. And fetal medicine unit queried whether there was some a Dandy Walker malformation, and they were offered a fetal MRI at that point. There was quite sensitive conversations had around what the family wanted to do, whether they wanted to continue with the pregnancy or they were given the option of a termination of pregnancy at that point. And the couple were really conflicted about what to do, kind of back and forward, speaking to local midwives and fetal medicine unit, and really unsure about the best decision for them. However, sadly, at 24 weeks, Sarah had reduced movement and came into triage, and sadly, a fetal death in utero was confirmed at that point. Sarah had an induction a couple of days later and went on to have a normal delivery of her baby, and her baby was on centile 52 at birth. The couple decided to decline a post-mortem. However, they did consent to placenta histology, and they were consented to the cord to be sent to cytogenetics. Now, really importantly, the consent process for sending the cord to cytogenetics is a verbal consent that is taken within the couple of days of baby passing. There's no written consent that we take at that point in time. And the couple felt really frustrated over the multiple conversations that was had around investigations and what was going to be sent where following their pregnancy loss. The couple had a postnatal debrief in Rainbow Clinic for 14 weeks after the loss. And a normal microarray result was given, but the family felt really upset as they thought whole genomic sequencing had been performed when actually this wasn't the case. Just a little side note, this book here that's just illustrated, The Pregnancy, Baby Loss and the Grief Journey, is a really powerful book that we often signpost a lot of our families to. It's illustrated beautifully, and it really helps families navigate that emotional journey and that grieving journey of what is normal after a pregnancy loss. And so if anyone is unsure and feels as though they need some support to help their families, this is a brilliant resource that's been designed by the University of Bristol, along with some parent involvement. It's a fabulous resource to signpost parents to. The couple were referred at the postnatal debrief into the genetics department, and were made aware that there was probably about a year waiting list at that point. And then, unsurprisingly, as often happens with our Rainbow Clinic families, the couple were pregnant 8 months after their loss. I did speak to the couple about their thoughts and their feelings around genomic testing, and I thought these quotes were really powerful to just really show how they were feeling and how they were thinking about it. They used words like frustrated. I had no answers. It just felt too long to wait. There was more waiting and more testing. And they, at the time of being of losing their baby and having those discussions around investigations, Sarah openly said to me that she really didn't see the reason for needing to have these testings undertaken and what the purpose was. And it's only afterwards, 11 months after the loss, where she's now able to look back, she can really see how important they are to inform this current pregnancy. So I suppose just there, it's a little pause for thought and just taking into consideration this family and this case study. And what was really striking to me, even as a Rainbow Clinic midwife and working in this field day in and day out, was I felt as though I had a really good handle on genomics and being able to talk to families about it. But actually, even just writing this presentation and talking to both Tina and Denise, it's made me realise I've got real big gaps in my knowledge and real areas where I need to go back and really focus on what we are actually talking to women about, to be able to feel comfortable and confident explaining these investigations and make sure these families are 100% sure about what they are consenting to. So as we can see here, parents seek investigations to understand why their baby died. It can support the grieving process. It does gather useful information for future pregnancies and it helps inform that. And really interestingly, and I suppose we see this in Rainbow Clinic, families feel really invested in research and they really want to contribute to research to try and prevent other families from going through the worst possible thing as a parent you could go through. So as you can see here, post-mortem placental histology and chromosomal analysis does give us a huge bank of evidence. We get a lot of findings from the placenta and that can then inform future pregnancies, thinking about medication changes if that's something that we need to add in for that next pregnancy. Post-mortem can sometimes discover potential fetal anomaly, which may have not been detected on ultrasound during the pregnancy. And that can then lead to a full MDT discussion as to whether we need to consider further genetic testing. And I suppose a little side note, it's really important to consider that ultrasound is only as good as the tools that we have, and it doesn't detect all anomalies. So for example, if we have a lady that does have a raised BMI or baby's in a difficult position, she has fibroids, it can sometimes be really tricky to detect that anomaly. And then it's again managing those expectations and those feelings, those thoughts that the parents have as to why that wasn't potentially detected antenatally. So I'm just going to hand over to Denise now. Sorry, Denise, cutting you off.
Emma. So in a way to try and standardise the offer and provision of genomic testing in England in all areas of healthcare, we have something called the National Genomic Test Directory. The one here is for rare and inherited disease. We also have one for cancer care too, and it contains the funded tests currently available with the associated R code or test request code. It sets out who's eligible for testing and which specialty can request them. And one of the common tests that are performed after a stillbirth is the R22, which is for a fetus with a likely chromosome abnormality. And the eligibility criteria for this test includes where there's been a fetal loss that's suggestive of a chromosome abnormality or a third trimester. And I've just altered this time frame to 24 weeks for clarity. So a loss from 24 weeks of an intrauterine death or stillbirth in the absence of any other likely cause like an infection or abruption. So let's look at this test in a little bit more detail, because I know from working with a lot of midwives, we talk about genetic testing and offer genetic testing to families, but what does that actually mean? So the R22 can be broken down into two parts. The first part is the chromosome analysis, or the QFPCR. The Q stands for quantitative, or I just remember it as quantity. So basically, it looks at the number of chromosomes that are present. And you might remember from biology classes GCSE or whatever is your equivalent, that our chromosomes are inherited in pairs. We get one set from our mother and one from our father. So by counting the chromosomes, we can identify when there's a atypical number of chromosomes in a cell, and this can be known as aneuploidy. So by looking at the number of chromosomes in the cells, we can quickly identify if there's an extra or missing chromosome. And we're quite familiar with Down syndrome or trisomy 21, and this is where the baby has an extra chromosome on pair 21. So that's the first part of the test. That can be done quite quickly. And the second part of the test is the microarray. Now, this is a little bit more of a detailed test on the chromosome, and it looks at extra pieces or missing pieces in the chromosome. And this can be known as microdeletion or microduplication. It can also pick up sometimes if parts of the chromosomes have been swapped over in an unbalanced way or an unbalanced translocation. And we know that too much or too little genetic information can cause problems in the growth and development of the baby, and this can result in stillbirth. And not all these changes in the chromosomes can be seen or are expressed visually as the phenotype, and so they can't always be seen on ultrasound scan. So this is why genomics can help to add to the information that we provide to families. There are limitations to the test. The chromosome microarray won't identify all genetic anomalies. So it's really key that the conversations we have with families, we never say that the chromosome test or the genetic test came back as normal, because there's no such thing. The arrays can't detect smaller changes or mosaicism when the change is not present in all of the cells. And it also may identify variants that we don't know the significance of, or that might not be relevant to actually why we were doing the test in the first place. There's also a chance that the sample might not give us a result. Sometimes the cells just don't grow and the lab really can't give us a result. And that's so upsetting for a family. But again, if we've not made them aware of that before the testing, it's a very difficult conversation when you're trying to provide some results for that family. And then we have the next level of testing. And I'm not going to go into too much detail. I'm very conscious of time, and also it might make your brain hurt, because it does me. But there are more in-depth levels of testing that are available. And the one I'm just going to pick up on is whole genome sequencing. And this is where we can look at not just the protein areas, we look at the whole of the DNA or the genome. Now, the reason this is significant is because a lot of the time, midwives and parents expect that this is the level of testing that's been done on their baby, and it isn't. This is a very specialised test. It requires a multidisciplinary team to actually review the clinical situation, and it's done on a case-by-case basis. And the testing, as I mentioned, is in the National Genomic Test Directory, and there are quite a few tests that can overlap. So it's not our gift as midwives to be able to offer this necessarily, but we need to be aware that there are other tests that might be suitable for that family, depending on their clinical situation, but to really reach out to the multidisciplinary team, which is your clinical genetics team, your obstetric team, your fetal medicine experts, really involve that MDT to get the right information for the family. The parents also have to provide informed consent, and this often involves a record of discussion and a signed signature or a verbal signature on a consent form, so that they know exactly what they've consented to, and they receive a copy of that result of that form. For most of the testing, there is advised that we test in trio. Now that means the mum and the dad and the baby. Now, this is often okay, but in some situations, obviously, we don't have one of the parents available to be tested. So some testing can still be done, but again, it's being really mindful of the level of testing that we can offer. And as midwives, we're trying to support families going through this. The wait time for the results can be, every week feels like a month or a year to these families when they're waiting for the results to come back. So to be able to know the turnaround times, which vary from different regions, is really important to know how to help support the families while they're waiting for the results. So linking in with your local team is really beneficial. These are just some papers on further testing opportunities that may be available depending on the clinical situation, and really starting to look at what's the chance of us being able to give an answer by doing more of these detailed genetic testing? What's the diagnostic yield of these tests? So these are some really good research papers to have a look at. So genomics can provide answers for families and help with family planning, but how do we improve the opportunities so that families get more of an informed offer and consent? So we've brought together a few key tips around having a really sensitive conversation by creating a safe space and enough time to have an informed discussion with families. I always wonder if that time on delivery suite, that first 24 hours when their world has been turned upside down, is that the best time to get informed consent around genetic testing and to discuss the implications, the limitations, and what it may yield? I'm not saying it is or it isn't, but it's just worth considering and really listening and empathising with that family, because you'll learn a lot for what matters to them by having that really informed conversation. And I'm hoping by the end of this session, you'll have a bit more confidence in explaining the roles of genetics and genomics to the families, discussing their options, as I said, the implications and limitations of testing, and also going into that more personalised level around the emotional support that's required, the ethical considerations that families might have to have. And even some families think they have to pay for these tests, especially if they haven't been born in the UK and not familiar with NHS care. It's really trying to understand what their priorities are. We're very well supported in the UK with different pathways. We've got the National Bereavement Care Pathway, which really helps to reinforce the good communication is really key to fabulous bereavement care. Continuity of care is so important, and really involving the families all the way through their care. We've also got the RCOG guideline, Green Top guidelines on care of late intrauterine fetal death and stillbirth. These help to cover the maternal wellbeing tests that we look for, that look at maternal health and recurrence risk. It covers the post-mortem examination, which can provide critical insight into the loss and also for future pregnancy management. Talks about cytogenetics, which I now hope you realise is QFPCR and array, and that's offered to all parents. And the really key area of this is that parents should be providing written consent to this test. So I'm going to hand back to Emma, because we need to see how Sarah's pregnancy progresses.
Sarah and John, they had been referred into genetics, aware that there was about a year waiting list, but they were pregnant again. So they had an urgent referral into genetics at about 9 weeks of pregnancy. They were seen by a genetic counsellor a couple of days later, and they consented to whole genome sequencing, and they had trio testing. What's really important to note is that testing did take about 9 weeks to return. There was no result for the 9 weeks, so that really long wait for that family must have felt like an absolute eternity. And there was no genetic changes identified in the result, and at this point the lady was about 19 weeks pregnant. The family were cared for by Rainbow Clinic. It was an incredibly challenging pregnancy. Sarah really struggled to bond with baby, couldn't watch the scans, couldn't talk about baby, couldn't project forward to think about having baby. But really lovely, really positive news that baby was born 4 weeks ago. Baby is thriving. Sarah is doing amazing, and baby is exclusively breastfed at 4 weeks old. So the couple are over the moon. So what can we do as midwives? We can continue to provide compassionate bereavement support. We have amazing bereavement midwives that go out of their way to provide care to these families during the worst possible time that they are going through. We're running the Improve course later in the year, hopefully in Manchester. So if anybody is interested in wanting to take part in that, then please do contact me and we can update you with the dates and times as and when that comes round. We can build relationships with clinical genetics teams in the labs, pathology. We can make sure that we know how to talk through postmortem consent and truly make sure we are consenting these families to genetic testing. We can create regional networks with our lead midwives, make sure we're reaching out and knowing who is here in the area. And nationally, really important to look at the Midwives in Genetics and Genomics network, our midwifery networks. We've got a Rainbow Clinic network, an NHS Futures page, a really good resource to share information share challenging cases, and update our skills as midwives. And what's really important to note is that practice varies massively around England, and we need to know our own policies. And what's even more important on that final note is the family voice, and we should be improving our care, taking into consideration these quotes from families and what they feel as though they need. So the key takeaways from this session is that we can get a lot of information from genomics, but there are limitations, as we have discussed. It can help us provide personalised and individualised care into that next pregnancy and ensure that families really know where to go when they become pregnant again, what the plan of care is going to look like, and what's going to happen in that pregnancy. It's important that we as midwives keep up to date with our own knowledge and any advancements in genomics as well, to make sure we can then pass on that information to families and feel comfortable and confident having those conversations as well. And again, important just to recognise that cultural beliefs can sometimes hinder those conversations as well, and it can influence how they feel about having that genomic testing. We've put together some resources for you as health professionals, but also for families as well. So signposting areas for families, but also super important for us as health professionals to make sure we are looking after ourselves, because it is a really tough job looking after families when they have lost a baby before. One resource that I didn't put on there was Ellie's Gift and Ellie's Rainbow. So Lucy has created some mindfulness sessions, both for families and for health professionals as well. And she does a weekly session on mindfulness for healthcare professionals. So a really good one to have a little look at. And be genomic curious, have a look into these education resources and just make sure we're keeping our knowledge and our skills up to date. And we know that hopefully in the future, there's a real opportunity to potentially create a learning package that we can supply to midwives and ensure that they're feeling comfortable and confident with having these open and honest conversations with families. Thank you.
Fabulous. Gosh, that was action-packed. Very action-packed. I mean, one of the interests, I mean, it's kind of, I just thought tats. It made me think this is another kind of pathway in midwifery and maternity services where there's another little language underway. There's something I hadn't, the turnaround times, that was really useful. And but it makes me realize that there's a lot to learn in the whole of the genomics. I mean, and I'm particularly, I would imagine, and our audience, this is the time you can put your questions in, just in case you're all sitting there stunned. And our presenters will answer the questions. But I'm thinking possibly the student midwives have this level of knowledge better than some midwives that might have been around a wee while. But is that a perception correct in your experience over the last year or so of doing this work?
I feel like the students have a better understanding and probably a bit more ahead of the game than a lot of the registered midwives. Even my daughter, who's 16, has just done her biology GCSE, and she said, "I've just been doing genomics, Mum, and done Punnett squares and patterns of inheritance." And I'm like, "Oh yes, that's great." So yeah, the education is getting there. I think the difficulty is, though, we learn about basics of genetics at 16 in our GCSEs, and then we don't get anything else really throughout the rest of our training. So I hope this has managed to inspire people to realise about the limitations of their knowledge, and that we do need to have a bit more information to be able to help families make an informed decision.
Okay. And is there a sort of package, do you think, that you'd recommend for a midwife who might be feeling very rusty on this within the work that you've done and the resources? Because I know you shared, and I would say all of these QR codes you'll be able to access, because the presentation, you'll all get a copy of the presentation, so you can access the QR codes and the references quite easily. But I just wondered if there was one that was, you think, oh, this is a really good starting point for people, or a good reference of any sort. I know you've recommended a lot as you've gone.
Yeah, I think we did look into this because I thought I knew enough about it to be able to talk about it, and it was just interesting to look to see what was out there. There are some really good resources on Genotes, which is like a just-in-time resource that it's aimed at clinicians who have a woman or a patient in front of them, and it talks through a clinical situation and what genomic tests will be relevant. I don't know that it's the right level for us as midwives. I think sometimes it's overcomplicated. So hopefully this resource that we've just created
This is
a start.
Well, this is, I mean, it's a bit like when people come and share research, it comes alive when people are talking about it. And I especially like Emma's case study, because that really makes it come alive as how important it is for families. And I'm so glad. Thank you, Emma, for sharing the end of the story, or part of the end of the story, because that's always important, because it sort of makes it all come together so beautifully. Right, we've got Rose. Hi, Rose. I'm feeding comments and questions as we go. Rose says, amazing, useful topic. Thank you very much. And then Patricia L. Williams, hi Patricia, says, agreed, felt I had lots to learn. And then Colette Grace, hi Colette, says, thanks so much, really useful. And then Susie has also got a comment. Thank you, Susie, for making this comment. We have a mismatch between the national guidance who recommended offering genetic testing from 24 weeks, but our local genetics lab in Cambridge have recently reduced their acceptance criteria to 28 weeks. So really not really a question, just an area of frustration when trying to provide optimal care. I don't know if anyone wants to comment on that. That's sort of, that feels a bit uncertain, doesn't it?
Yeah, I think the change from 28 weeks to 24 weeks for the R22 test that we specifically focused on for the talk only happened last month or the month before. So the National Genomic Test Directory updates every year, depending on what the evidence is showing. And this was based on feedback about the ability and the clarity around, some people were classing the test as third trimester, so 28 weeks, and some are classing it as 24 weeks. So they've just clarified that tests can be done in the National Genomic Test Directory, which supports all the laboratories, from 24 weeks. But it's only a recent update, so it might be that it takes a little while for it to filter through.
Right. Well, that's a good point. So the clinical area may have taken a bit of time to catch up. Yeah. That's really helpful. Thank you. Fabulous. Okay, so Susie, take that back. And then we've got Katie Snutch, who says, we also use the Cambridge lab, so we have the same issue. Is there any way of overcoming? Well, I think this is obviously a time thing. Now, as we all know, that it's like when you get a piece of research that comes in, sometimes practice takes a while to catch up, and sometimes protocol and policy documents take a while to catch up because we've got to update everything. So it's always useful, I think, to go to the online processes if you have any queries, and you've had this feedback now that you can take back to your units, which is useful, and make sure it's up to date. Okay, and I've got another comment. Oh no, this is a question. Cara with a K. Hi, Cara. And if a family has had a stillbirth many years ago and they had basic genetic testing and a post-mortem but nothing significant was found, could the results be looked at again and any further tests be done? Cara, that's a fab question. Now, who's going to answer that one? I think it might be Emma. If there's, I mean, and this would be thinking about all these crime things. I don't know if Cara's been looking at CSI, but when they re-look at crimes and then they can re-look at different tests as tests have improved. I don't know.
I think that would be very much down to the genetics department as to whether or not they're able to rerun that test. But it's definitely worth asking that question.
Okay, so getting in touch. So Cara, getting in touch with your local genetics team. Now, how do we find out where our who are these people? Who are these wonderful people? And how do we, as practitioners, find out who our people are? Because again, it's about person to person, isn't it? Because you can get a lot of information by contacting someone and just asking. It might appear like a daft question, but actually, Cara, that was a brilliant question.
Yeah, no, that's a really good question. I think so we have regional clinical genetics teams. So a bit like, well, we have the 7 GMSAs, the 7 genomic medicine services, and we also have different labs attached to those. So different regions, depending on the geography of their own local unit, there will be a clinical genetics team. And if you work in maternity, if you're not sure, you can speak to if you have a genetic counsellor, or if you have your screening midwife, there'll be staff who are quite in regular contact with the clinical genetics team. So it should be fairly straightforward to find out and ask those questions.
That's a fabulous resource, isn't it? I mean,
yeah.
One of the things that you can do and if I'm sort of addressing student midwives, but also midwives if you're in a new unit, getting to know these people and getting information from your screening midwife or genetic specialist is really useful. And I used to keep a little file with useful contacts with this information, because then you know where to go when you have an issue. Useful to do, and that's really good, because these people know, they know this different language, and they can explain things like Emma and Denise and Tina explain so beautifully. So just in case you have forgotten, she said, okay. No, you've gone all quiet. They've gone all quiet now. Very quiet. Any more questions before we kind of start? I'm just going through, because I thought these the resources you have are fantastic. Now I'm saying to the audience, you need to go through the slides. Now one person, and I think that was Patricia, wanted the PubMed reference, but you just need to go to the slide. I can't remember what slide it was. Was it 10 or 11? But just link it in. You'll get the presentation anyway. And I had a question while you were talking about what tools you can have. Because one of the most difficult things, and that was coming through in a couple of presentations, was making sure the woman and her family, or the pregnant person, or the family have understood the screening process, and especially being that you're talking about times of 8-9 weeks of waiting for results. How do you test whether they've understood what you've told them? That might be one for Emma.
It's a really difficult conversation to have, because nobody wants to say to somebody who's desperate for a result, you're then going to have this testing, and then you've then got another wait. But I always find, in my experience, it's much better to have that open and honest conversation with them early on to make sure they're fully aware of it. It's obviously a verbal conversation that we have at the postnatal debrief appointment, but that then is also backed up with a letter as well. So we send that letter to them. And what we find is that we often have quite a lot of preconception ad hoc telephone calls with these families, where they're ringing us to ask us extra questions before they're actually becoming pregnant.
Right.
So even in that period between them having the loss and then becoming pregnant again, we often do get ad hoc phone calls where they're asking a few things, or clarifying something, or querying whether a result is back.
And that's probably the rainbow clinic kind of concept, which is embracing this lovely continuity and making families feel safe enough to contact, even with little questions that worry people.
Absolutely.
Oh, fabulous.
Yeah, and I suppose a really shameless plug, but if anybody does want support with trying to set up a rainbow clinic, please let me know, because I am more than happy to help. We can help support business case planning and writing, and we're developing an e-learning package for hopefully rolling out to other rainbow clinic sites, and we've got a great bank of evidence to help support that kind of offer if anybody does want it.
Fabulous. So anyone who, now this strikes me that the comment, the kind of this whole concept of contacting you and setting up a rainbow clinic, this would make a lovely practice development project for any midwives out there who are really into supporting and bereavement midwives out there, but also students who might be looking at this for their dissertations. Have this in mind, because I think it's this sort of time people are working on it, but this is a really good thing to work through. And it's an amazing number of rainbow clinics that have been set up, and what a fantastic resource for women and families. Fantastic, absolutely wonderful. Now I've got just some more comments, I think. No, just more thanks, and how fantastic that was. Anyway, just as well, because as I always say, this this hour always goes the fastest of the week, definitely. And I'm sure the conversation will continue, and we know we've got more of this to come over the next few months anyway. So I want to say a big thank you to Denise, Tina and Emma for joining us and sharing the genomics and helping us understand it. Please do share with your colleagues, share with your friends, and talk about this, because it's an really important issue, very important for us to keep up and get up to date with all of this and not be out of kilter with it. I want to also say thank you to Angela, who's making sure this is always going to be smooth, and you'll get the recording and the podcast at 6 o'clock in the morning on Friday and next Thursday on the newsletter. That's fantastic. Thank you to Paul for feeding through the questions also. Now next week we're going to look same place, same time, and we're looking at the midwife's role in facilitating early connections. And we've got Inga Nicol, who's director of the Brazelton Centre, and Stephanie Kinder, specialist midwife at North Bristol. And those I'm just doing another call out for anyone who wants to come to Manchester to our North Festival. We've got some fantastic speakers, and it's a good place for a mini break, I have to say. Very good place. And also I should have mentioned this early, because that was on my little news piece and it slipped my mind. But isn't it nice that we are members of a family of 853,707 NMC registrants? Isn't that nice? Of course, we need more of those to be more midwives. I'll come off my soapbox now. So in the meantime, stay safe, stay well, and enjoy the sunshine wherever you are. Keep cool as well. And we'll see you next week. And thank you for joining us. Take care.